I'm thrilled to be here. Thank you guys all for being here. You're the reason we get up and go to work every morning and try to do better. Unfortunately, we all like working with each other, so it's always a privilege to see colleagues as well. I'm going to try in 20 minutes to talk a little bit about the surgical management of NETs. I'm going to focus on small bowel and pancreatic NETs, so I know that might not apply to everybody in the room, but that's kind of going to be the focus because we can't get through everything in a short time. You've seen this slide. The incidence of neuroendocrine tumors has been increasing. Nothing special about that other than we've just seen this continued trend, which is a positive thing in the sense that people are probably being more accurately diagnosed earlier and earlier, and there's more work being done to treat patients. As you all already know, NETs can arise anywhere in the body. Typically, we can find them in the lung, the pancreas, the small intestine, the rectum, the colon, the stomach. And certainly there's some differences between treatments, which you'll hear about a little bit later today, but treatments vary based on tumor location. It's not a one-size-fits-all approach, and surgery is exactly the same. You've also heard a statistic that says frequently patients are misdiagnosed. This was something that was published on World Net Cancer Day a few years ago, and 1 in 2 patients who were diagnosed with other conditions when they actually had neuroendocrine cancers. So once you are diagnosed, you are fortunate to have people like Bob and Marianne and other support groups that can really help you navigate what to do next. So that's certainly a privilege once the diagnosis happens, but keep in mind that if you feel that something is wrong with you, it's important for you to continue to go to the appropriate medical team who can help you figure out exactly what that is, because oftentimes you know your body better than we do. What should you expect with a NET diagnosis? Dr. Suarez kind of talked about this. I think your goal should always be to connect with a NET specialist. We've heard about the NET Centers of Excellence. And really what should happen when you meet with a specialist is they should really be discussing your options and why they are right or wrong for you, right? Neuroendocrine cancers, zebras, not a one-size-fits-all thing. Different things may be appropriate at different time points. Surgery may be appropriate at different time points. So it's important to kind of have an understanding of where all of this fits with your particular tumor type and your diagnosis. Our responsibilities as a physician is to be able to explain to you in easily understandable terminology what is going on and what we're thinking. We should be able to provide you with a list of options. Sometimes we don't have a list of options, but it's important to know that that's the case, right? And then we should be able to provide you with the pros and cons of the option and how it relates specifically to you. And ultimately, the 2 of us, 3 of us, your families and us, and our entire multidisciplinary team should be working with you to make that appropriate decision. It's really important for the patient to tell us also specific things. What are your symptoms? What is your lifestyle? What are your goals? What are your treatment preferences? A lot of times patients will come to us and you'll say, hey, I think we should do chemotherapy. Oh, well, you know, my uncle had chemotherapy and he was miserable and he was in the hospital and I absolutely don't want that. Well, that's something important. So-and-so had surgery and they had this horrific complication and I absolutely don't want that. It's important for us to know that, one, so that we can help guide you, potentially redirect you, and inform you how your experience might be very different from what you've seen in the past. And you have to be open-minded. I think if nothing else, you may come in thinking that you absolutely don't want something, but at least hear us out. And allow us to tell you why we think that could be a good option. How do you choose your surgeon? You don't really have to like them too much. You do have to trust that they're going to do a good job. Try to find a specialist. So have they seen or done this before, right? Not infrequently I'll get patients who say, oh, the surgeon who removed this said, you know, he's only read about this in a book. Okay, well that's probably not the right person to go back to necessarily. It may have been the best person at the time. It doesn't mean that they have to do this and just this every day. Keep in mind when you're asking surgeons, how many of these cases do you do a day? We may be doing the same type of case for multiple different pathologies, right? I take out stomachs for stomach adenocarcinoma, you take them out for that, you take them out for GIST, you do the same thing over and over again. So you want to have an understanding that they're doing the same type of procedure, but also that they understand neuroendocrine tumors and kind of the different multimodal therapies that might be available for patients. You can ask your surgeon if they participate in a tumor board or work with other NET specialists. So a tumor board, we basically all sit around and talk about you and why we should be doing what we're doing. And depending on who has the loudest voice or had the most coffee that day, they win. But ultimately, you want to trust in your providers, and you have to feel empowered to add your own perspective because that's important. Do not be afraid to seek another opinion. We don't have feelings. We actually do. But as Dr. Suarez said, we would be happy for you if you found a team that you're comfortable with. Okay, so it's important to us. Again, this is kind of more of the same. So I'm going to give a little bit of background, which you've already heard from Dr. Anthony's talk, but we kind of break these things into functional and non-functional tumors, and we're deciding what to do with surgery. Functional and non-functional makes a difference. Because certainly for things that are functional and overproducing a specific hormone type, if we remove or are able to remove that tumor or a majority of the tumor, your symptoms dissipate, they go away. If, however, they're not functional, meaning you feel otherwise completely fine, depending on the degree of disease and where your disease is, we may opt not to go to surgery first, right? So these are important things. But functional. Functional essentially means that you have symptoms from hormone excess. Carcinoid syndrome, which you've heard of, means it produces types of hormones which can cause flushing, diarrhea, bronchospasm, carcinoid heart disease, anxiety, things of those variety. And then there's a subset of pancreatic neuroendocrine tumors which are functional, and they secrete a specific type of hormone made in that cell type of the pancreas, and those can cause very specific symptoms that are not referred to as carcinoid symptoms, right? So these are important. Non-functional is me before a cup of coffee. So that should give you some idea. It means you're asymptomatic and there's no symptoms of hormone excess. And then there's a lot of terminology that goes around, as Dr. Suarez mentioned, sometimes on the pathology report, depending on where it was reviewed, you might get, just neuroendocrine tumor, neuroendocrine carcinoma, neuroendocrine neoplasm. So there's a little bit of variation, and this slide is just kind of to help you navigate some of that. I'm not going to read everything. With respect to pancreatic neuroendocrine tumors, we have specific guidelines in terms of when we should resect them. I'm talking about pancreatic neuroendocrine tumors who have not yet metastasized to other sites in the body, not specific to lymph nodes. So not in patients who have liver metastases or lung metastases or bony metastases, just a plain pancreatic neuroendocrine tumor. If they're functional, meaning if they're producing a specific hormone and giving you symptoms, we want to take them out because a lot of times not only is it curative, it treats the symptomatology that you're having. And so those are things like insulinomas, gastrinomas, somatostatinomas, VIPomas. If they're non-functional and larger than 2 centimeters, we routinely want to take them out. Sometimes we can do this, and I'll talk about this in another slide, just by taking out that area. Sometimes we have to do a bigger operation depending on where it is. If they're less than 1 centimeter, non-functional, we have pretty good data that suggests that we can leave those in place and watch them because they tend to grow quite slowly. The key is they do need to be watched. And if they're 1 to 2 centimeters, there's some variation, there's some controversy, among surgeons and physicians in terms of, are they growing fast enough? How complicated is the procedure? What would that look like for the patient? And if we're watching you, can we just wait for something to grow or change or look more suspicious for us to take it out? And in patients who have high-grade tumors, if it's just that tumor in the pancreas and it's nowhere else, again, surgery can be curative, so we frequently will want to take those out. So again, the current guidelines that we follow, you can observe tumors that are less than 1 centimeter, resect patients who have tumors that are bigger than 2 centimeters, and then we should individualize decisions, which is where you also come into play in terms of what to do with the 1 to 2 centimeter ones. What exactly are we doing when we're doing the surgery? So I'm going to have you kind of focus on that circle there. So this thing is the pancreas. This thing is the duodenum, or the first part of the small intestine. This purpley blue thing is an important vein called the superior mesenteric vein. It goes up here, connects to another one, and goes into the liver. This is the superior mesenteric artery, and that's the artery that essentially takes blood and gives it to all of your small intestine. So you can see that the pancreas kind of sits in an area of pretty important real estate. And when we're determining what to do, it's important exactly where the tumor is sitting. So you can imagine that this brownish circle that we've drawn is a little bit smaller. It's kind of on the edge of the pancreas. And so you can imagine that we can potentially just cut this thing out, right? So that's called an enucleation. So depending on where your tumor is, what it looks like, this may be an option, and it allows us to preserve a good proportion of your pancreas. So if it's an option, it's something that we'll do for a well-differentiated tumor. Sometimes, however, it's the red circles, right? And so that looks more central in the pancreas. You don't really have to be a doctor to figure that out. There's a duct that runs through here called the pancreatic duct. It's important. It's the thing that takes all the enzymes back and dumps them into your duodenum so you could break down food. And then these vessels, they break the pancreas up into the head and the tail. So you can imagine that if I have to, you see this blood vessel here, it's called the gastroduodenal artery, and you see how it kind of gives blood flow both to the pancreas and the duodenum. And a lot of times if we have to take the pancreas here, we end up having to take this artery. And these guys are pretty intimately involved. They're like best buds. You can't separate them. So what ends up happening is if you have a tumor in the head of the pancreas, you end up requiring a procedure called a Whipple. And what that means is that we're taking out this whole section, so kind of where these lines are. Now, when that happens, we have discontinuous segments. So your stomach doesn't have anything to empty into, your bile duct doesn't have anything to empty into, and your pancreas doesn't have anything to empty into. So we have to bring up a piece of intestine and reconnect everything. So a Whipple is a pretty big operation in that it requires a lot of reconstruction, right? And anytime we reconnect things, there's a possibility that they could leak. There's a possibility that they just don't want to participate for a period of time. Sometimes your stomach decides not to wake up for a while. So the reality is that's a bigger operation, right? So if you had a 1.6 centimeter pancreatic neuroendocrine tumor that was sitting smack dab in the middle, and it required a Whipple, and it had all very favorable features, we may have a conversation about saying, hey, let's watch this, and let's see. And if it doesn't change, well, we're not going to do this whole big thing. But if it does, or if anything is suspicious, we can still go ahead and do this, right? So those are patient and tumor-specific factors. On the other hand, if it's this guy, well, then you can just essentially cut off this part of the pancreas and there's nothing to reconstruct. So that's a very different operation potentially for that patient with the 1.6 centimeter tumor. What about small bowel? So this is the most common site in the GI tract. We have an incidence of about 10 to 12 per million patients who are diagnosed with small bowel neuroendocrine tumors. 35 to 40%, potentially even higher, of them are multicentric or multifocal, meaning there's more than one site kind of within 100 centimeters of each other within the small intestine that has another deposit of tumor. They're typically well differentiated, they're slow growing, but they can present late. A lot of times you may not really know that anything's wrong until something all of a sudden is. So this is just a picture when we're looking at a scan. Typically they're small. This is a larger one where you can actually see the mass in the small bowel, and there's usually associated mesenteric nodes that are involved. I am going to show some pictures, so you may, if you see something that you don't like, just close your eyes. And they've been screened by other NET patients previously, and they said, no, this is fine, so you're okay. But just in case. So the benefits of resecting your small bowel primary are essentially that it could be curative if it's early stage, as Dr. Anthony mentioned. It can prevent future metastases, both local and distant. It can prevent or alleviate bleeding or obstruction. So a lot of times patients will present with intermittent abdominal pain, nausea, vomiting, and it's because either those tumors themselves have caused a blockage, it's just like plumbing, right? And if stuff can't go through, you're not going to feel so great. Or it's because the associated nodes that are sitting next to the small intestine can also potentially cause a blockage. They can decrease blood flow to the intestine, giving you intermittent abdominal pain. There's a slew of symptoms that we kind of need to ask you about. But living with pain for, we have patients who come in and say, oh, this is normal. This is just what's been going on for 10 years, and it hurts after I eat. And so I just eat less. Well, okay. But it's important if you're saying that to someone and they're kind of saying, well, that's just you. No, go see someone else. And it can improve survival. So at surgery, and this is where you get to divert your eyes if you need to, but really the approach depends on the extent of the disease and the tumor location. The key point for small bowel tumors, as I mentioned, they could be multifocal. So your surgeon should discuss with you the need to actually manually palpate, meaning they need to touch your small intestine, because sometimes the primary tumors honestly are as small as a sesame seed. And the instruments that we have, so when we're doing robotic surgery, we have no haptic feedback, meaning I can't feel anything I'm doing. I'm depending on visual cues because I've done it enough times to know that I'm putting too much stress on something, that there's something firm right there. It just doesn't look right when I'm holding it, but I can't actually feel anything. When we're doing things laparoscopically, it's kind of like operating with chopsticks with a little less sensation, so you can imagine that you would miss something if it's really, really small. So essentially what we want to do, if we do laparoscopic or robotic surgery, we typically still want to make a small incision where we can either put our hand in or you pull it out, right? And here you can see the incision's not terribly big. I mean, this is my, oops, go back. This is my hand up here, tiny, tiny incision. We can pull up the bowel and kind of feel everything and feed it back in. Yeah, absolutely. And then here the incision's a little bit bigger because the patient had a larger mesenteric mass. So the size of the incision can be different. We remove the associated nodal disease. I'll show you that on the next slide. And then cholecystectomy. Not infrequently, we talk about taking out your gallbladder when we're in there doing something else. Certainly if a patient has early stage disease and we have no anticipation that the patient will require a somatostatin analog, which can cause biliary colic or gallstones, you don't necessarily have to have your gallbladder removed, but if we're going in there to take out metastatic disease and taking out your primary tumor, then frequently we'll take your gallbladder as well, because you don't really want another operation, even though the risk is about 30 to 40%. So the approach for these small bowel tumors, essentially, as I mentioned, this is a big blood vessel, right? The same one that we saw where the pancreas was. Here's the pancreas. This patient had a Whipple in this illustration. Part of their colon's removed, but that's a minor detail. But you could see that same artery that's supplying blood to the whole small intestine. Well, a lot of times the tumors in the small intestine can be really, really small, just like this dot on a laser pointer that I have. But sometimes you can have a really big mesenteric mass. So depending on where that mesenteric mass is, we will essentially identify that spot and then take out the appropriate segment of small intestine. And you can see here, this is essentially the lymph nodes follow the channels of the blood vessels. And then for purposes of a resection, you end up taking the area where the tumor is, and then you kind of take a pizza slice to get the associated arteries and blood vessels. So for small bowel endocrine tumors, if they're metastatic, for symptomatic patients, we resect the primary tumor. In asymptomatic patients who are metastatic, there's some controversy. It's certainly something we discussed yesterday among the physicians, but we do think that there may be some benefit in select patients, so it should be a discussion point. Many patients will have metastatic disease at presentation. I'm going to talk a little bit about liver metastases. So there's many different ways we can treat liver metastases, and it depends on the degree of metastases, right? So in this patient, you see a few large tumors, a few smaller ones. We can easily remove this. This would be much more difficult to remove. This we would not be able to remove, right? So in different patients, different options. And the purpose of this slide is to say, you know, when we say, what is the next step? What I'm thinking is the disease only in the liver? How much burden in the liver do you have? And then all of these options exist. And like I talked about, they may be appropriate for you at a given time point. So you can flip-flop back and forth between any of these, which is why it's important for us to work together and with our multidisciplinary teams. We consider cytoreduction for net liver metastases when we can get at least 70% of the tumor out of the liver, or if we could burn 70% of the tumor for patients who have grade 1 or 2 nets, and typically we want patients to be healthy surgical candidates. So what do I mean? There's some of you who have or will develop, or know others who have had carcinoid heart syndrome. Sometimes that could be debilitating, so you may not be a candidate, but we fix your heart to do something about your liver. We want to make sure that you're healthy enough to tolerate a large operation. It's beneficial because we think it improves survival. Here, just those, similar to the slides that Dr. Anthony showed you earlier, this is kind of what we're basing the data on. We've looked at patients and said if we can take out 70 to 90%, it improves survival and it slows down the progression of your disease. When we're looking at it as surgeons, we kind of have multiple different approaches in terms of what we're going to do depending on how much tumor you have. For neuroendocrine tumors, we typically want to spare the parenchyma, meaning we want to leave as much liver behind as we can, because typically when you have liver disease, and even if we do a resection, the risk of it coming back is quite high. So over 80%, 5-year recurrence in the liver. So a lot of times we know that we're buying time, but we want to leave you with enough liver so that you could have other therapies or other surgeries or other treatments should those tumors come back in those different locations. So this is a patient in whom we've removed numerous liver metastases. In total, I think I took out 17. but these were the larger ones. And you can see that you're kind of able to just wedge out the tumors and leave plenty of healthy liver behind. We could do this minimally invasively. Like I said, no haptic feedback. I'm over here in the corner. The robot is helping me do the work. And this is what we're seeing on the screen. We can do ablation. We could do that in the OR. Again, we're here. We're looking at the liver with an ultrasound. We can see where the tumor is on the ultrasound here, and then we're able to kind of put a probe in and burn the thing. So surgery can be a potential for cure, resets the clock, and with newer techniques, we have decreased complications. And I think I'm probably out of time, so I can stop talking, but no one's stopping me yet. So what about after surgery? They're afraid. No. Your recovery depends on the type of surgery. We've only talked about 2 types, but it depends on which organs. Did we take out small intestine, colon, pancreas? Did you have lung surgery? And the duration of the procedure. The goal is that you're not this guy when you're showing up to the OR and saying, oh my God, what are those stirrups? You have an idea of what this is going to look like. This should be a conversation that we have. And recovery all depends on your overall health, right? So it's important for me to know that my patients are healthy. I tell everyone I expect you to walk for an hour a day before we go to surgery. And that's your homework, because if I gave you a pill, you'd probably take it. So I think you can go walk. So prehabilitation, diet, exercise. What do you expect after your procedure? You're going to have some pain. Pain will not be a 0. I would love for it to be. It varies based on tolerance. Women tolerate pain much better, in case you guys didn't know that. Sorry, gentlemen. You will be expected to walk the day after surgery. We are not amputating your legs. You will be started on a diet eventually, unless you had lung surgery, in which case you'll be started on a diet immediately after. And how long you stay in the hospital is based on the above. What happens after that? You have your routine follow-ups. You'll see your surgeon. You'll see the rest of your net team. What should you be doing? Keep a log of questions that you may have. And again, if something doesn't feel right, call us. Don't say, well, I had an appointment with you in 2 weeks, so I just didn't want to bother you. No, bother us. I need to know. If I just operated on you and something isn't right, I need to know. And with that, thank you.